Now, moving on to the next section, that is the clavicle fractures. In this, we will be going through briefly the mechanism and the clinical features of the clavicle fractures, what are the different types of imaging which can be utilized to assess the clavicular fractures, and what are its classification and how to manage the different types of clavicular fractures. So what is a fracture clavicle? As you know, it's commonly called as a collarbone. In children, it gets easily fractured, but usually the good part is it invariably unites rapidly. So in children, we usually do not need to operate it most of the time. Even in adults, most of the time it is not needed to operate, but sometimes it may be associated with certain injuries in which the indication for surgery becomes mandatory. As you can appreciate over there, this is the shoulder girdle. The proximal humerus is associated with scapula, and there is this is the acromion. This is the coracoid process where the short head of biceps comes into play. Long head starts right from here in the scapula, goes through the rotator cuff, and then joins the short head later in the forearm. And the clavicle is actually attaches this just to the shoulder girdle. So it's normally called as collarbone, but it has a very important function because it attaches one upper limb towards the chest wall cavity. Normally it's 2.6 to 4% of the time it gets fractured. Almost 35% of all the shoulder girdle injuries, among the shoulder girdle injuries, almost 1/3 of it, very commonly clavicle gets fractured. Most commonly is the midshaft. Actually, the clavicle is divided into three parts. There is a lateral 1/3, there is a middle 1/3, and there is a medial 1/3. Usually, there is a bend called as it's an H-shaped bone between the lateral 1/3 and medial 2/3. This is the curve that is there, and this is where the curve is. This is the most common site of the fracture in the case of the clavicle. Most of the time, it's undisplaced, but it can be displaced as well. Lateral fractures, actually midshaft, middle 1/3 is around 70%. Lateral fractures is usually 20 to 28%. And medial 1/3 is very rare, but it can also happen 2 to 3% of the cases. Now coming to the mechanism of injury. Now mechanism of injury is common, and that is why it's so commonly injured in case of shoulder girdle injuries. It includes fall on the shoulder on the outstretched hand. If suppose the right clavicle is injured, it's usually associated with RTA, with the person falling out on the right side, or person falling in such a way that it's trying to hold something to protect itself, and then the hand is outstretched. The force is transmitted from the wrist joint all the way up through the elbow to the shoulder. This may result in fracture of the clavicle. Commonly, usually the midshaft fracture is the middle 1/3. That is the most common. It results in the lateral fragment being pulled down. Why? Because there's the weight of the body. If you see, this is the point. If it gets injured, there will be muscle forces acting on the lateral 1/3, and they're going to pull the fragment down. And this medial third, or medial half of it, is actually being pulled up by the sternocleidomastoid muscle, and it is actually displaced upward. Most of the time it's undisplaced, but once it displaced, the medial goes up and the lateral goes down. As I just told you, it's due to the lateral goes down due to the weight of the arm, and medial goes up due to the pull of the sternocleidomastoid. Now coming to the mechanism of continuing with the mechanism of injury. Usually the fractures of a lateral end could be close reduction is impossible. Why? Because sometimes they may be associated with acromioclavicular disruption as well. Lateral displacement is sometimes there, but sometimes they can be completely displaced. Usually there are two ligaments which is called as acromioclavicular ligaments, which is one of them is a trapezoid and there is a conoid. If these ligaments are intact, there will be little displacement of the fracture, but if they are torn, if both are torn, then there will be more displacement. If one of them is torn, there will be definitely displacement as well. Sometimes this could be a severe displacement due to torn acromioclavicular, that is the trapezoid and conoid torn. If fracture is medial to these ligaments, now there's a problem over here as well. Sometimes what happens is that they are not torn, but the fracture is actually medial to the where these ligaments are actually attached on the distal 1/3. Therefore, that the medial segment which is there is actually not attached to the lateral segment, so it becomes a free segment. Therefore, that becomes an indication for surgery, because you cannot keep it in free, because if that is going to be kept free, that will be that will keep on going either upward or downward due to pull of the muscles, and may damage the neurovascular structure. So then it becomes the usually the indication for surgery. Coming to the clinical features, what will be the clinical features? Arm would be clasped to the chest to prevent movement. Definitely there will be pain on the shoulder movement. Subcutaneous lump or obviously swelling would be present over here over the collar area. There may be a sharp fragment, which is usually this fragment which is being pulled upward, which thirdens the skin. There may be a vascular complication, although it's very rare, but it can happen with the rupture of the subclavian vessels. The outer third fractures may be mistaken for acromioclavicular joint injuries as well. There is a specific type called as near type 2A. They may be confused with acromioclavicular joint disruption. Now, if it's a vascular injury, that is a clear-cut indication of a surgery. So then again, we have to see the patient as a whole, whether there is associated neurovascular injury or not, is there any associated injury with the brachial plexus or not, and then what is the fracture type and how we can classify it. Coming to the imaging, first and foremost in orthopedics are always the X-rays. And on X-ray, you can get a simple AP view of the shoulder joint along with the chest, and you will see probably this is the kind of a picture is. The lateral is going down and medial is going upward, and this is actually a middle 1/3 fracture, which is almost the most common fracture, 60-70% of the time. Then it could be taken with 30-degree cephalic tilt. Now, why this cephalic tilt is there? Because usually our shoulder is in 30 degree of retroversion. So to make it a true AP, we have to take it in a cephalic tilt at times. Now coming to this, usually a fracture in the middle third of the bone is very much visible, and it could be in the outer 1/3 or it could be in the medial 1/3 as well. But usually it can be missed at times as well. Medial third fractures usually maybe the X-ray of sternoclavicular joint X-ray may be needed. So there is specially called as serendipity view, which is specific for associated sternoclavicular joint dislocation or fracture which may be associated with the clavicle. So when we are seeing the medial 1/3, we have to make it sure that there is no associated sternoclavicular joint dislocation as well. Clinical union precedes radiological union by several weeks, and this is usually common because patients usually become pain-free by 2 to 3 weeks, and they can carry out their daily activities. Usually bone unites by 4 to 6 weeks of the time as well. Now coming to the other imaging, sometimes a CT scan may be required, although it's rarely required unless we are planning for surgical fixation, and there is definitive indication of surgical fixation as well. But CT scan with 3D reconstructions can be done to determine the degree of shortening at times. Diagnosis of sternoclavicular fracture dislocation, if we are suspecting posterior fracture dislocation, this is very important to establish whether the fracture has united or not, or there is maybe associated non-union long-term pseudoarthrosis of clavicle as well. So that to rule out whether there is associated pseudoarthrosis or it's a united fracture, we can go for CT scan as well. Now coming to the classification, it was actually classified into different categories. As I told you, the clavicle bone has been mainly classified into 3 portions. There is medial 1/3, middle 1/3, and lateral 1/3. Now the group 1 includes, which is the most commonly, is almost 60 to 70% is actually the middle 1/3. So they are further subdivided to displaced and undisplaced, and so they are called as group 1A or B. Then this group 2, this is called as Neer's classification for clavicular fractures. Group 2 is actually the lateral 1/3. They are further subdivided into multiple other subgroups because there could be Neer type 1. Neer type 1 could be acromioclavicular ligaments become intact or not, because if they are intact, usually there will be minimal displacement. In type 2 fractures, usually ligaments are torn and the fracture line is completely displaced. In type 3, there is intra-articular extension of the fracture, and then that is actually precludes to surgery at times as well. Sometimes what happens is that ligaments are not torn, but what happens is that the fracture is actually medial to these ligaments. That puts them into the medial third fractures. That is why, because medial third fracture mean that the ligaments are intact, lateral portion is intact, but the medial part is actually free, and there is sternocleidomastoid which is attached on the top, which is going to pull the fragment upward. So that becomes a relative indication for surgery as well. Now coming to the treatment. Most of the time, the surgery is not indicated. The absolute indication for surgery is actually either there is a neurological injury in form of brachial plexus injury, vascular injury in form of subclavian arteries may get injured as well, or there is an open fracture, or this medial fragment is impinging on the skin is such that this may be eventually become open, or there may be impinging on the muscles and subcutaneous fascia as well. So these are the absolute indication. All other indications are relative indication for surgery as well. At times somebody may be saying that once this clavicle may get united, there will be a large lump, a bump, so I don't need that. Probably that is a relative indication for surgery at times. Now, treatment for most of the time, middle third fracture is actually they're treated non-operatively and in form of polysling or cuff sling. That is usually a simple sling for comfort is given for 2 to 3 weeks, and then the gradual range of mobilization of the shoulder joint is started, and eventually at 4 to 6 weeks the maximum range of mobilization can be initiated with regular exercises for the muscles. Now coming to this is a clavicular hook plate which can be used for in case of lateral 1/3 or middle 1/3 fractures of the clavicle, depending upon if there was an indication for clavicle fixation or not. For example, if it's a near type 2 fracture which could be mimicked by acromioclavicular joint disruption along with the coracoclavicular joint claviculavicular ligaments injury, or this could be even near type 3, or this could be even in which there is intra-articular extension. Sometimes you need surgery so that to prevent later on arthritis of the acromioclavicular joint. Therefore, then it could be plating, intramedullary fixation as well. There are multiple methods of fixing it. There could be hook plates, as there's a need in the near adjoints model. There could be other plates as well. Could be interior and or superior plating. Intramedullary screws have been used as well. There was also use of K-wires at times as well to reduce the fracture. Later on, the K-wire removed. But again, there are different pros and cons of each and implant which may be utilized, and its own benefits and risks as well. Now coming to the lateral third fractures, why they're important? Because they are the ones which are actually associated with acromioclavicular joint problems. So they have to be dealt in a separate category, and there is a near classification for that. In simple way, we can make it minimally displaced or extra articular. And these are types. The other could be usually if they are extra articular and minimal displaced, the treatment is non-operative, and that is sling for 2 to 3 weeks. Now the problem starts when it's either intra-articular or it's completely displaced. Now why it get really displaced? If you see this diagram, normally this is where the trapezoid and conoid ligaments are actually attached. If the bone is broken from this and gone up over here, this means there is not only apposition as well as there is completely more than 100% displacement. Either this could mean two things. This means that either both the ligaments are injured, or at least one of them is injured as well. Usually when this much displacement is there, most of the time both the ligaments have got injured actually. Now displacement, if they're displaced lateral third fractures, now usually you need surgery for stabilization. Why? Not only because this is going to eventually lead to acromioclavicular joint arthritis, you need to repair the coracoclavicular ligaments as well. Although operations have higher complication rates, but that's need to be done. Coracoclavicular screw or plating can be used. There's a screw called as Bosworth screw which has been used as well. There's a modified Weaver-Dunn procedure as well. There's a Femister technique as well. There are multiple options which we can do this. This is called as hook plate fixation. Clavicular hook plates have now been newly introduced as well. So especially in the displaced lateral third fractures. Now coming to there are different techniques which could be called as suture sling techniques, in which either you repair the coracoclavicular ligament or you use some kind of a graft which is an autograft for the repair of coracoclavicular ligaments. Our Dacron graft ligaments are also being now introduced, which is actually a synthetic material which can act as a coracoclavicular ligaments. Now coming to the medial third fractures. Now medial third fractures are of importance because they are involving the sternoclavicular joint. And you know that in the sternoclavicular joint, in the mediastinum, there are very structures which are very important. They are actually lying, for example, our vascular structures such as the aorta, they may lie in the posterior mediastinum. There may be heart which is in the superior mediastinum, and then there is actually a trachea and esophagus which may be lying anteriorly as well. So that is where the problem starts. If there's a medial 1/3 fractures, they usually extra-articular, but and there is associated with anterior displacement. Anterior displacement is not an issue, but if that can be managed non-operatively. But if it is posterior dislocation, it may impinge on the trachea, and initial fixation is like with the complications. The problem is posterior dislocation means it's impinging on the trachea, and that can compromise the trachea later on and can be very disastrous for the patient. So that for that reason we need to fix it. And then the different suture and graft techniques as well, and newer locking plates and staples have been actually introduced as well for the fixation of medial 1/3 or so medial third clavicular fractures, along with the posterior dislocation of the sternoclavicular joint. Now coming to the complications. Complications divided into early and late complication. Early complication includes pneumothorax, damage to the subclavian vessels, and brachial plexus injury. Late complications include could be non-union or malunion. Non-union could represent in form of pseudoarthrosis of clavicle, and once the patient is being kept immobilized for a long period of time, this can lead to stiffness of shoulder joint. In this section, we have briefly gone through what is the clavicular fractures, what are the different classification of clavicular fractures, and how to manage the clavicular fractures. Most of the time they're managed in a polysling. They're only unless there is a specific indication for surgery. The absolute indication includes neurovascular injury along with the open fracture. All other are relative indications for surgery, but sometimes the classification is important because if it's lateral 1/3 associated with coracoclavicular ligaments injury or the intra-articular extension along with the displacement, then probably surgery is a good option for early rehab of the patient. But if it's undisplaced and there is no coracoclavicular ligamentous injury as well, or if it's middle 1/3 involving the middle 1/3 of the collarbone, then probably the immobilization in the sling for 2 to 3 weeks and conservative management is a better choice. Thank you very much. Keep watching sqadia.com.